Good afternoon, everybody. Welcome to our third webinar in our Rural Health webinar series. Today, we are going to focus on the topic of leveraging innovation to improve rural health care access. We are pleased to be sponsored in this webinar series by Centene, and we'll talk a little bit more about our plans with Centene, not only for the webinar, but beyond. Uh, my name is Vijay Chauhan, and I am the Global STL lead at BioSTL, a nonprofit that's based in St. Louis, working on building an innovation economy in the area of biosciences over the last 20 years. One of the projects that we have been implementing at BioSTL is building ourselves into a magnet, our region into a magnet to recruit high quality, cutting edge innovation from around the world to our region. And we've been doing this in healthcare and in the area of agriculture and food. And to recruit that innovation, we wanted to first build a big buying power magnet. So we got together with all the healthcare organizations in St. Louis, and then over the last few years, expanded that into 5 Midwest states. And we have close to 20 healthcare organizations now that we convene on a regular basis to understand what their innovation needs are, what their strategic priorities are, and that with that understanding, go out into our global network and source the best innovations that address their needs. So that platform now is made up of these 20 healthcare organizations whose revenues add up to $360 billion, which is a tremendous amount of purchasing power, about 10% of US healthcare spending. So we are now able to showcase to any innovator in the world, if they want to do business with 10% of US healthcare, this is the place to come. Having done this, we have built a very significant toolbox of digital health innovation. And we asked ourselves, how can we now take this toolbox of innovation and can we now bring it to our rural communities? And so this is what we are doing with our project in rural healthcare. We want to connect global innovation to the rural economic engines of healthcare, agriculture, and food, because those are often what drives rural economies. And so one of the things we are planning to do is a symposium on rural health and economic vitality. When we talk about health, we take the broad vision and understanding of health. And health and economic vitality are two sides of the same coin. So we are keen to revitalize rural communities, build rural-urban partnerships, and we have a symposium that we are planning in fall 2021 that is sponsored by Centene. What is the focus of the Rural Health Symposium? We've been spending a lot of time with rural communities and organizations who have relationships with them. And based on our discussions with them, we have come to understand 4 major challenges rural communities face. First, it's around healthcare access and affordability. And today's webinar is going to be a focused topic around that. Healthcare capacity, whether it's hospitals, workforce, major challenge in delivering that capacity in health in rural settings. Oftentimes, solutions that can address this require telehealth, and telehealth requires broadband. So you see very quickly, affordable high-speed broadband is the third focus area. But broadband is not just for healthcare, but for very much the economic engine of rural communities, just like electricity was 100 years ago. So it is for the agriculture, for workforce development, for e-commerce, for citizens who live in rural communities to live their lives and get connected to the world. And the fourth area we're focusing on is the social determinants of health that are hyper-indexed in rural communities. Loneliness and isolation, the opioid crisis, social determinants of health related to transportation, access to fresh, healthy food, and housing. So those are the 4 areas we're focusing on. And to do our work in a very effective way, we've been convening a large platform of different vectors that intersect and care about and bring value to rural health. From the healthcare organizations that you saw in our earlier work on the global STL side, We've now expanded into more rural healthcare organizations. Rural communities are the real heroes of our story. And so spending time with community leaders who are making change in the community, as well as the communities at large, are part of our platform. Industry groups like the Missouri Farm Bureau, the Missouri Rural Electric Co-ops, academic partners who've spent a lot of time thinking about research in this area and understanding what works and what doesn't from a research standpoint. As you can see, technology is going to have a huge role in how rural economies are going to run and rural health will be deployed. And so we've been working with technology partners. We have more coming online. We're also talking to corporations that have rural healthcare employer presence, and then the state itself with the Department of Health and Social Service, as well as the Department of Agriculture. And then we are connected and working with national experts and researchers who are focused on this topic. So this big platform has been what we've built over the last 18 months. And in that work and through our outreach into rural communities, in Missouri alone, we have started to build partnerships with rural communities. And what you're seeing here is a map of the 4 areas that are focus of the healthcare work that we're doing and what those communities interest and how they intersect with those 4 areas. So we are really pleased to share with you a very significant engagement with rural communities that has now taken place. The webinar series that we started was because of the momentum that we built with our rural communities. And we've already done 2 webinars, one in January around rural communities in action, and the secrets of success to creating health and economic vitality through innovation. The second one was on how to leverage 2 proven models for creating change if rural communities want to come together and do that. Having spent time with rural communities as the center of our webinar series, with this one, we are now focusing on improving rural healthcare access. And that's what the focus is of this webinar. We then plan to have our next webinar on the 9th of June, focusing on the issue of affordable broadband and coming up with some innovative models for doing that. And then we have our fall rural health symposium. We are in ongoing discussions. We may end up adding a few more webinar topics between June 9th and the fall symposium. And so with this as the topic, leveraging innovation to improve rural healthcare access, I wanted to give you a context for the gap that exists when it comes to rural health in Missouri. So some information that a lot of people in rural communities already know, but I wanted to make sure that our larger audience understands, is that 99 of the 115 counties that we have in Missouri are rural. And over 55–60% of them have no hospital. Adding to that, we have a sizable population of folks in Missouri who live in these rural communities, 37% of our population, and yet only 18% of physicians who practice in Missouri practice in these rural areas. So right there, you can see almost a 2-to-1 disadvantage in terms of the allocation of physician resources to folks who live in rural communities. So we know that there are many issues to access, but this one points out one aspect of that. And we will never be able to bring on as many physicians as rural communities need. And so we are saying, how can we look at innovative approaches for addressing this problem? So today we want to feature 2 cutting-edge innovations in rural communities. One is a company, Babylon Health, that came from the UK, that has built a 24/7 primary service that literally exists in the palm of your hand. And they will be talking about their wonderful work that they are doing in the Boot Hill area with 10 counties through a unique partnership with Home State Health. And in fact, this project is the first deployment of this model in the entire United States. And Babylon Health came to St. Louis through the 2018 Global STL Health Innovation Summit. So we run an annual health innovation summit between our healthcare organizations and innovators from around the world. And they came here in the 2018 conference. The second is in the area of cardiology. As you all may know, the #1 reason for mortality when it comes to health-related issues is cardiac health. So that's the number one mortality creating condition. And so access to cardiologists is really important for all of us, particularly for rural communities. So we're going to showcase an innovation that provides 24/7 oversight of a cardiologist, again, in the palm of your hand. This is a company called Koala Life from Sweden that came to St. Louis in the 2019 Health Innovation Summit. To cover this topic, we've got a really good lineup of speakers. We've got Nathan Landsbaum, who is the president and CEO of Home State Health. We're really, really happy to have Nathan talk to us about what Home State Health is about and their plans with their partnership with Babylon. Representing Babylon is Dr. Marcus Zachary. He is the global lead of value-based care for Babylon Health. And then representing Koala is Dr. Jerome Dwyer. I like to call him Jerry. He is a cardiologist with extensive work in both urban and rural communities at the St. Louis Cardiology Center, and he is a clinical advisor to Koala Life. We also have Leanne Parker, who is a registered nurse, done extensive work in rural health as a hospital administrator, and doing now a very innovative model for deploying Koala in underserved rural communities. And then we have the voice of the patient, Donald Melvin, who is Jerry Dwyer's patient, who got to experience the Koala technology and how it had helped him and Dr. Dwyer figure out what's going on with them. So that's the panel we have today. So the conversation is going to be in three parts. I'm going to have a conversation with Nathan and Marcus on Babylon, talking about their work there. The second segment is going to be a conversation with Jerry, Donald, and Leanne about their work on Koala. And then I'm going to have a third segment with just the healthcare professionals, Marcus, Jerry, and Leanne, talking about their ideas on what rural communities and rural healthcare needs and should become. So with that then, let me stop my share and welcome Nathan Landsbaum and Marcus Zachary to the webinar. Nathan, Marcus, such a pleasure to have you. Welcome, and really appreciate you all giving us the time to have this conversation.
Yeah, our pleasure. Thank you for having us.
Thank you.
Great. So Nathan, I wanted to start off with you sharing with the audience a little bit about Home State Health. Give us some context for the services, the mission, the values, your footprint in Missouri. Starting there would be very good. And then ultimately we'll want to talk about what was the burning platform or the issue that you were wanting to tackle as you were thinking about the Babylon project.
Yeah, sure. Thank you very much. And before I get started, thank you, Vijay, for having us. It's a pleasure to speak here about this very important topic. Really high-level overview of Home State Health. We are a wholly owned subsidiary of Centene Corporation. We manage the healthcare needs of over 370,000 Missourians along three products. So first and foremost, we started almost 10 years ago in Missouri as a Medicaid managed healthcare company. Today, we manage the healthcare needs of around 270,000 individuals in the Medicaid managed healthcare program. That's about a third of the program overall in the state. We are statewide in every single county. On the marketplace side, our product is called Ambetter, and we have just under 100,000 members across the state of Missouri. We are in most of the state. The only region we are not in is central Missouri. But in the other regions, we have about 100,000 members, and that's good for about half the total market share of Missourians that purchase their health insurance through the marketplace exchange. And then lastly, we have a Medicare product. It is called All Well today. It will be called WellCare in 2022, and we have just under 5,000 members in the major metropolitan areas, St. Louis, Kansas City, and Springfield right now, and growing that product fast.
Very good, Nathan. Thanks for providing that context. And so, can you share with us what was the strategic issue that Home State was trying to address that required sort of a fresh new approach?
Yeah, well, we're always looking for innovative ways to engage our members. So, what we are trying to do primarily is to engage our members in their own healthcare where they're at, and everybody gets engaged in a little bit different ways. So, meeting them where they are from a healthcare perspective. The greater we engage our members, the more likely they are to control, manage their healthcare conditions. The better outcomes we'll have, the lower costs we will achieve, and the better quality we'll have and patient satisfaction. So really just wanting to make sure that we outreach and have access to as many of those members as we can, because everything that we do and try to succeed at is tied to engagement.
Got it. So engagement is the problem that you're trying to solve and looking for innovative approaches. And so with that background, thank you so much, Nathan. I want to have Marcus, you tell us a little bit about Babylon, its mission, the problem in healthcare that it's trying to solve, and share with us a little bit about your global footprint, if you will.
Sure, happy to, and thank you so much for having us participate. It's a real pleasure, especially to present with Nathan in Home State Health. So Babylon, our mission, very simple but audacious: affordable, accessible healthcare to everyone on Earth. That is our mission, and I would say as a sub bullet to that. It is an emphasis on primary care, proactive care, because we know that if we are proactive about taking care of ourselves, a lot of good things will come from that. Less use of going to the hospital, specialists, and that's a real value for everyone. So Babylon, as Vijay mentioned, founded in the UK. We started with a single GP practice of 1,500 members over 2 years, scaled that to 90,000 members, the largest GP practice in the system. The reason we were able to do that is because Babylon, at its core, to achieve its mission of affordable and accessible healthcare, made a heavy investment early on in developing world-leading artificial intelligence and automation, where as much as possible, we try to have medical care, some of the tasks that otherwise are performed by human beings being done in an automated fashion. That allows us to extend our reach, making the healthcare more accessible and obviously thereby more affordable. And the evidence was in our ability to scale a single clinic to a panel size of 90,000 members. Then that led to the opportunity to actually do the first value-based program, where we've taken a quarter of a city's population from one of the city trusts in England and have full responsibility for that population. Then through a Bill and Melinda Gates fund, we had the opportunity to take our model to Rwanda, where we deployed the same model using our virtual digital capabilities, which extend from interactions on an application on a phone, where you can go through a symptom checker to get immediate information about symptoms you're having, to digital health risk assessments. You can do chats and virtual consults with real live doctors. That effort in Rwanda was successful and led to a 10-year agreement with the government. And as a result, primary healthcare is free in Rwanda for all its citizens, and they get that through Babylon. So that's a little bit about who we are and how we developed our footprint globally before coming to the United States.
Great, thank you, Marcus. So Nathan, I wanted to ask you, how did Home State and Babylon connect? And what is the problem you are trying to solve in terms of this hard to reach population? And if you have any statistics to tell us, and then why did you select the Boot Heel region for this project?
Yeah, so BioSTL, that's how we got introduced. So little plug for BioSTL. I don't think we would have found Babylon, at least not when we did, if it wasn't for them showing up to BioSTL and connecting with our innovation folks. So yeah, that's how it started. And really our relationship with Home State and Babylon started January 1st of 2020. And Babylon started statewide as a telehealth provider for us. And it was really before the pandemic even started. So we didn't just started utilizing telehealth as a vehicle to reach our members as a result of the pandemic. We utilized telehealth far before that.
Got it. Mm-hmm. And so tell us about, the project in the Boot Hill area. How did you select that? What was the problem you were trying to solve?
Yeah, so Babylon reached out to us and wanted to do something unique, a value-based arrangement with a telehealth provider. That's something that you don't hear about every day, and so it really piqued our interest. And our state, like other states, have areas where access to healthcare is not what you want it to be, and the outcomes and quality reflect that. And so we started looking at areas of the state where we had low member engagement, and then of course high costs, high acuity, low access, and low quality. And Southeast Missouri, by many measurements for us, really fit an ideal location. So we chose 10 counties in Southeast Missouri. Really, if you go from Poplar Bluff over to Cape Girardeau and then shade the entire state down in the Boot Heel, you've got the area that we chose. Another reason why we chose this area is because we've heard about healthcare closing up facilities in rural areas. And the most recent example in Missouri is Twin Rivers out of Kennett, Missouri. And so the healthcare for those folks in Southeast Missouri, in particular the Boot Heel, became much more complex when Twin Rivers closed up. And we thought that it was an ideal location for us to try out this pilot.
Great, thank you for that background, Nathan. So it was the folks at Babylon coming to you and saying we wanted a value-based arrangement. And Nathan, Marcus, I want to ask you, what were you guys thinking? You guys were crazy there?
Well, I do have to give a shout out to Nathan and his team. This was not something that had ever been done before, and so it took a lot of courage to do this with us. And we certainly we had concerns. What would the regulator say? A digital first assignment to a primary care provider. But at the end of the day, we had seen our results in other regions of the world. We felt confident that we really have something, and we just particularly me in the United States, having experience, really felt like this was going to be a good fit for this population and serve them well.
Great. So in line with that, there's a question from the audience. Is the value-based arrangement with Babylon a global cap arrangement or an upside only arrangement?
So it's, so I would say that is proprietary, but there is upside and downside.
Got it. So appreciate the sensitivity around that question, but I think what the audience needs to understand is, Marcus, you basically have taken ownership over the health of this population and are doing everything to make sure that you are improving the health while managing under a certain financial ceiling for the care of the person. Is that right?
That's right. And along with that, the outcomes, we're looking at customer experience and of course the quality.
Got it. So it's member experience, it's the quality of care, and then the cost, which is the triple aim, I guess, in the world of healthcare. Everybody's been wanting to deliver triple aim. You guys have put your money on where your mouth is to deliver that. So to help the audience understand, Marcus, tell us about the unique model of care that you have been doing. I understand this project started in the Boot Hill area in October 2020, so it's really early days for you all. A lot of learning to come out of it. But it'll be really wonderful if you can talk about the model, and maybe you can talk about it from a patient perspective first. So what does that journey of a patient look like? What's unique? What's different about it? And then we can talk about how that works through the backside of it, through the provider side. So maybe you can start on the patient side.
Sure. Yeah, and I previously started to describe sort of from a technical standpoint some of the aspects, but there is that digital front end entry, starting with the ability to automatically engage, but then you can chat, virtual consults, and then behind that, there's a huge team. So it's doctors, it's care managers, social workers, dietitian, health coaches. We also have community healthcare workers that we put into the community. And I should mention that the majority of these people were hired from the region because their local knowledge about the healthcare system, about the members that we're serving, and their community is really important to our success. And so for the members, I think an important concept that I think is critical and why I'm a big believer in value-based care is it absolutely is crucial, and we are incentivized to be very proactive in outreaching to the members where we can, using any information that we can gather. We want to find the folks that are the most at risk, but we actually attempted to contact the entire membership within the first 3 months of starting this program. We weren't always successful, and we tried and continue to refine that approach. But the first job is get out there, make contact, and get them to start on their journey. So what the member experiences is if they have a smartphone or access to a computer, they register and they begin to digitally go through an assessment and inform us about their health. They are then outreached by someone on the clinical team with the goal that we want to get everybody on a care plan. And then once we've established that, have them have a virtual visit with their doctor, who will essentially sign off on that care plan. And then through follow-up interactions with the care team and with some what we call our monitor solution, they get electronic nudges if they are allowing it on their smartphone or computer. We want them to complete that care plan. And then, of course, if there's any concerns, changes along the way, the team is there to guide them through it. And then beyond the direct care that we give, if they need to go to have a test, if they need to see a specialist, we have a team that helps them make those referrals. And then if there is more clinical information from those events, we make sure that we have that information so that our doctor and our medical record are the source of truth. So for the member, basically through the Babylon app, they're able to manage and access the entire healthcare continuum. That is the intent.
And that's 24/7, Marcus, meaning a person.
Yeah, 24/7 on demand, anytime, anywhere.
Got it. And so are these folks just Medicaid? There's a question from the audience. This is just the Medicaid population, right? Not any of the other Medicare or Marketplace. It's just
Yep.
Medicaid members.
That's right. This is the pilot that we're working on with Babylon is Medicaid only. However, Babylon also provides services to our other members and other products as well throughout the state.
Got it. Yeah. So this pilot is Medicaid only, but across the state, it is all three of your
services are provided
services.
by Babylon for telehealth. Yep.
Got it. So Marcus, how many people are we talking about that are in this 10-county project?
So I think we are now running about 17,000.
Got it. And of the 17,000, how many have you been able to engage with so far? It's only 6 months in.
Yeah, so we have over 5,000 people now who are in some form or fashion on that care journey that I described.
Got it. And so I know it's early in your implementation, but can you tell us sort of, how it's going? What are the early indicators that are telling you that it's heading one way or the other? What's working? What's not working?
Yeah. So, I think we did a lot of diligence coming into this. And one thing that we knew we were going to encounter was what we called the unwired folks, people who don't have access to the technology. And so we talk a lot internally about equity. That is the basis of the mission, that there should be equity when it comes to human health. And we didn't want the technology to somehow get in the way of that. So we pushed really hard to make sure that even with a basic telephone landline, that we were able to deliver the majority of the care as intended. So we spent a lot of time working on that. Anecdotally, social determinants of health is a lot of what our interactions are focused on. So food security, housing security, and so forth. And then in terms of leading indicators, what we've seen is out of all these members that we've been working with, we always are asking, what would you have done otherwise? And over 40% of the time, they're reporting that they otherwise would have gone to the emergency room or a hospital or an urgent care. And we're seeing validation of that starting to come through in the claims information, that the usage of the hospital, the usage of the emergency room are dramatically lower. But all the while, we're seeing anywhere from 97 to 98% customer member experience. So that's great to see that high satisfaction. So it is early days, but the leading indicators are really encouraging.
And so it was really great to hear you talk about this issue, Marcus, about equity, right? Because while one can get all excited about a sexy phone with an AI chatbot, for a lot of people living in those areas, that is just not their reality for a whole host of reasons. The internet access is weak, the data plan is not there, and it's all in and out. So was this something that you all figured out here in Missouri, or did something happen, your experience in Rwanda give you some kind of an insight into this issue?
Yeah, I would say it's a mix of both. I think we had already, we didn't invent community healthcare workers, but as a company, we had begun to build that into our clinical program and have a process and R&Rs, if you will, for using folks like that because of this experience in Rwanda. I think home state health was the first time we really had to push our thinking and really dig into the product. I spent, and this is how we refer to it internally, breaking things, trying to figure out where can we do this with just an audio call and really pushing the product team on that point, so that, again, there was just, I did not want there to be a limitation just because somebody didn't have, as you said, a fancy phone.
So Marcus, I want to have you share, we were hoping to have a patient of yours provide her journey. She unfortunately had a strep throat and could not join our call. So, if you can help us with this, love to have you talk about, a patient journey. So I'm a patient X, this is my life. Tell us about how that Babylon experience would feel from a patient perspective.
Yeah. So yeah, unfortunate. Yeah, no COVID, but strep is still out there. In this particular member's experience, they had some abdominal pain, and then had not had the opportunity to become eligible yet for Babylon. And so what did they do? They went to the emergency room, and a film was taken where they were looking for something to do with the pain. This member was basically told, there's nothing wrong with your belly, nothing to worry about, all's fine, all's well, go home. That patient subsequently ended up becoming a Babylon member. And as we began to build the clinical record for this member and reach out to them and take them through the journey that I described, it turned out later, after the member had left, the next day when the radiologist read the film, this member actually had a significant abdominal aortic aneurysm. This person, a former smoker, is at risk for this. So we informed the patient of this and arranged for them to have an ultrasound. The good news here is that it was not unstable, and now the member on a monthly basis gets regular screens to see if the aneurysm is stable. And at some point we'll likely need some kind of procedure, but otherwise would have had no idea that was there, and literally could have had a catastrophic outcome. But
yeah, go ahead.
Yeah, and I was just going to say, and this is part of the story is about Babylon and access to care, but this is also about value-based care and making sure that you have that whole view where you break down those silos. The ER physician wasn't thinking about a AAA. They were thinking about anything with the abdomen. Patient's discharged. The radiologist reads the film the next day. There's not anybody who's accountable for chasing that member down to inform them. And so these are just some of the issues that we deal with in healthcare, particularly in the United States today.
Yeah, thank you for sharing that very specific example, because it kind of illuminates the model where if you don't have somebody who's your advocate, who is there as your partner in your journey, you're out there on your own, figuring it out by yourself, and it's very episodic and it is very siloed. One provider has one view of yourself, the next one has another view, the two of them don't know what the total picture of the patient is. As you said, you had to build the full medical record. I mean, what a statement, right? You had to build a full medical record. This is the challenge that we have. So, and then what I also heard you say is you just don't think about it from a medical standpoint. You're thinking about the whole person, the whole health, the social determinants. Do you have some examples of that, Marcus, of some of the kind of social determinants of health that the needs that you're seeing and how you are solving for it?
Yeah, I mean, honestly, one of the things that we do for this population more than anything else is help them get food vouchers. There is an example of a member who had as a result of the pandemic lost their job, and it was going into winter. They couldn't afford to pay for the heating bill. It had been a tough winter. One of our staff was able to get them linked with a subsidy program through the utility company, so that they could continue to have their heat through the winter, which was significant to that individual. And there are many stories like this, and this is some of the challenges. I think, the message I would want to take to this audience and those in healthcare is that these people are not negligent about their health because it's some kind of conscious thing. They are dealing with some real life challenges, and so life takes priority, and their health, takes a back seat. And so what we spend a lot of time doing is first dealing with these issues before they're really mentally ready to address their actual organic healthcare needs. And so I think that if you can get the care to them, and you are able to be prepared to address these real social determinants of health, then you really can make a difference, not only in their lives, but also in their health.
Great. Marcus, thank you for sharing all of that. Nathan, I want to now ask your perspective. It's still early days with this experiment. From where you sit and based on what you're seeing, what is the impact you're seeing of this model, the Babylon model, on your members, on your providers, and then the mission of Home State Health?
Yeah, well, I mean, for a population that has been relatively disengaged, and by that, I mean, really without a medical home, a lot of people understand that terminology. We identify those members, and just to address a question in the chat regarding interaction with the other providers in the area, I just wanted to make it clear that what we have tried to do is avoid as much as we can any disruption of existing provider member relationships. So we can see that in our system, who has been to see a physician, a hospital, and who has established a medical home, which we can identify in our system. And so we wanted to make sure that Babylon was reaching out to people who had chronic conditions, but have not seen any primary care physician in over a year. So and what we have seen so far, given the numbers that Marcus has provided, is really what could be. Now, we need some time for that to mature, but what we could see is as much as a 3 times in terms of improvement in our engagement. So the engagement of this population is generally about 20% lower than what we see as our statewide average. And out of the 17 to 18,000 members now, for them to make contact with 5,000 of them, you're talking about a significant improvement, 3 multiple in terms of engagement, if that relationship is maintained. And that is an astronomical improvement in basically what is a little over a 6-month time period. Now, it will take a little bit more time for us to see the outcome improvement, the quality improvement, because it takes time for chronic healthcare conditions to come under management, and for those quality care gaps to get closed. But so far, the engagement and the satisfaction and the feedback that we're getting are 2 very early, very positive data points.
Very good, Nathan. I really appreciate that perspective of engagement. It's just staggering, right? 3 times higher level of engagement through this model. This is a population that was hard to reach in the first place. You guys tried everything that you knew in the book to create engagement, and you needed something new and different. And so Marcus, really congratulations to your team. I know you all are very early. One very simple question, you all are not from here, you're from UK. How did you build trust and relationship and credibility with your rural communities?
Yeah, I mean, it starts with Nathan and Home State Health. The partnership, the collaboration at all levels has been truly amazing. And I think that's the most important thing, that we've been hand in hand in solving our challenges. I mentioned earlier that when we were building the team, we built it local. That local knowledge is not something that's taught. And so we really wanted to leverage that with people who shared our mission and commitment to this community. We have a partnership with NowPow. So they are someone who helps us. And then there was the point about the providers through Home State Health's introductions. I've been leveraging Zoom to meet with providers in the community and get their help, get their information. Yeah, we know where our business goes. So, for instance, one of the big hospitals making contact with the medical director of the hospitalist program there. I'm a hospitalist myself, knowing how critical they are to our members moving through and building bridges. So, there's still work to do in terms of building the community. We're now getting to a point where we're going to start a little bit more door knocking. We couldn't do that initially because of COVID, but getting out in the community and being more visible. But really the intent here is we go into a region or market and put down deep roots, because that's really the only way for the long term that you're going to get the results.
Yeah, Marcus, thank you. It's a affirmation of the old maxim, right? Healthcare is local. You can have all the whiz bang technology in the world, but at the end of the day, it is a human to human local business. So, right. We could go on some fantastic audience questions. I'm so sorry we'll never be able to get to it in this call. Nathan and Marcus, I want to thank you for your participation in this webinar. And Marcus, will have you back on the last segment of this webinar. Nathan, really appreciate it.
Yeah, thank you very much, Vijay. And thank you, Katie, also for organizing. Really appreciate it.
Excellent. Thank you so much. And now we're going to have a second innovation project that we want to showcase with you. I want to welcome Jerry Dwyer. And I also want to welcome, let's just start with Jerry right now, and then we'll bring in Donald here in a few minutes. So Jerry, tell us a little bit about yourself and the work that you do as a cardiologist, and how did you get introduced to Koala?
First of all, thanks, Vijay. I also want to thank Nathan and Marcus for a fabulous presentation and discussion. I always learn something from the experts, so I thought it was great, and welcome. I am a St. Louisan, so I grew up here. I attended St. Louis University and St. Louis University School of Medicine. I did my cardiology fellowship and my EP fellowship at Washington University here in St. Louis. I'm a full-time practicing cardiologist, electrophysiologist. My flagship office is at Missouri Baptist Medical Center, a BJC facility. But pertinent to this, I have satellite offices across southern Missouri. I travel down 44, Highway 21, Highway 55. So I have been in that area for 25 to almost 30 years, servicing some of the sickest hearts. Washington County is one of the poorest and also one of the worst cardiac counties in all of Missouri, and I'm proud to take care of those folks and for many years. I'm a doctor, developer, and entrepreneur. I went back and got my MBA from University of Missouri Columbia in 2014. I'm involved with innovation and invention companies worldwide. I work with startups. I work consulting with Japan, Israel, the UK. I also participated in 9 clinical trials over the past 30 years. predominantly in the pacemaker and defibrillator space, and I'm an expert in cardiac remote monitoring. So as far as giving back to the community, I chaired the new opening fundraiser for the $550 million SSM SLU hospital that is located here in Grand in St. Louis. I sit on the board of trustees, as you mentioned, for St. Louis University. And I've been involved with outpatient cath labs since '91 and cardiac centers 25 years. So I'm really blessed and enjoy taking care of people every day. With respect to your question, how I got involved with Koala, as you stated, it was 2019. At your request, they were attending Global STL here in St. Louis. And of course, VJ introduced me to them as well. They were from Sweden, Philip and Dan, and I was given the opportunity after multiple discussions to help with their expansion to the US market with their small wireless 2-channel recording device. We are going to go through this with Donald, one of my patients, in a little while, but it is amazing technology. I actually fell in love with it at the conference, and it's been really a great journey and a valuable tool. It is a mobile app that patients, providers can look at real time for their cardiac arrhythmias. And it also has the capabilities to listen to heart and lung sounds, which is just fabulous. It can detect a number of arrhythmias, including atrial fibrillation, which affects 65-year-olds and older, 9% of the population. So that alone makes it incredibly valuable moving forward. Presently, we're working on a number of protocols, post-AFib ablation with Mercy, Dr. Doshi, monitoring the heart and the heart rhythm remotely for not only the St. Louis patients, but the rural outreach patients as well. And we are in the process of going to do a post-TAVR procedure, a protocol to follow the TAVR patients for 30 days after discharge. So these are just a few things. And I also currently participate as a consultant for the medical and business, and I chair the U.S. Medical Advisory Board for Koala, which I thought was important.
Very good, Jerry. Thank you for that amazing background that you have, your expertise in innovation combined with your work in the clinical and research space. So help the audience, we all know heart disease is the leading cause of death. Help us understand what is the issue that you are faced with when it comes to these arrhythmias. How big is it? What is the challenge with dealing with that issue? And what was it that you saw in Koala that says, aha, this thing's going to be able to do something that my current solution set cannot?
Well, first of all, as I stated, it's wireless. There are no sticky patches. It is a high quality 2-channel ECG recording device. It transmits and measures in real time with real feedback to the patient and to the provider if necessary. We're going to go through a demonstration with Donald in a short while, and I believe a picture is worth 1,000 words, and it is just amazing technology. Now, like I said, I deal with arrhythmias all day long. Some of them are benign, simple skip beats, but also ones like atrial fibrillation, which are very important to diagnose and treat and decide long-term outcomes. Of course, supraventricular tachycardia, VTAC, VFib, those are not necessarily benign. So when a patient comes into the clinic, they have palpitations, which could be one of many things, including stress, anxiety, to a real cardiac arrhythmia that could be potentially life-threatening, or even worse, possibly a stroke as well.
Great. So I want to welcome Donald Melvin, who is a patient of Dr. Jerry Dwyer's, and has used the koala. So Donald, welcome to our webinar. We are so happy to have your voice and your experience, and thanks for sharing. Tell us a little bit about yourself and how the koala became part of your life.
Well, I'll be glad to. It's always a pleasure to talk about my friend and what my wife refers to as my koala bear. Do not forget your koala bear when you leave the house. But it was in 1996 that I encountered my first supraventricular tachycardia event, SVT. I thought I was having a heart attack. Went to the hospital. My heart rate was 210 to 220. That's when I first met Dr. Dwyer, which began a 25-year wonderful patient doctor relationship, which continues today. I have told Dr. Dwyer on more than one occasion, you cannot retire until I die. And so I don't know if he's agreed to it or not, but he described in great detail SVT, what it was, and that there were a number of meds that I had available, that he had available. And we would start, he used the analogy of a ladder with the rungs up a ladder. And he said, we'll start at the bottom. As you go up the rungs, the medicine becomes, stronger and the side effects greater. So I did indeed go up a rung or two. And that's when he started talking to me about this thing called an ablation. Well, at first I was resistant. I said, let's go one more run. Okay, one more run. Well, that was a mistake. At that time, I traveled a lot in my profession, and I also did a lot of public speaking. And one of my greatest fears was being on an airplane and having an SVT attack. You're stuck. You're stuck for the duration. Or being, in the middle of a presentation and having an SVT attack, which was be very embarrassing and very unprofessional. Well, thankfully, that never happened. Neither one of those happened. However, in 2003, I was at a NASCAR race at the Talladega Motor Speedway. It's a 500-mile race, a long race. And throughout the entire race, I was going in and out of SVT. And at the end of the race, near the end of the race, I couldn't get it stopped. So my friends took me to what's called the Infield Care Center, a little hospital there in the infield. They got it stopped and wanted me to go to a Birmingham, Alabama hospital. Well, at that time, the race had just ended and 125,000 people were rushing out of the complex to get to the highways, to get home. It would have been hours to get to Birmingham. So they took me via helicopter. And when I got there, of course, as I expected, I did not have a heart attack. It was SVT. So as soon as I got back to St. Louis, I went to see Dr. Dwyer and I said, okay, doc, I'm ready for that ablation. And he said something as, well, I wondered when you would come around to this. And so that ablation took place in 2003, was very successful, and all went well for the next 16 years for the most part, a little blip here and a little blip there. But in 2019, I started having some arrhythmia issues. It wasn't like the SVT, it was something different, although it was still very uncomfortable. So Dr. Dwyer performed a nuclear stress test on me, and also said, okay, I want you to use a monitor. And I thought, oh boy, here we go. I've had that before.
Yeah, why don't we show what the old monitor looked like? It was wires and patches and stickies, right, Donald? And I don't think you were going to be very pleased with me
Please
at this time. So.
Yeah, the stickies all over you, the monitor, and not being able to sleep, well at night. And so he said, no wires, no stickies, no hassle. Knowing that I had a technical background, he said, you're going to be impressed by this. And so he introduced me to the koala. And indeed, I was very impressed. But about
Donald,
that,
yeah, go
I'm
ahead.
sorry, go ahead.
I wanted to have, having said this, I would love to have you maybe demonstrate the koala. And as that's happening, Jerry can talk a little bit about what that whole thing, the koala is doing for patients, and then how it helped you and Jerry with your heart condition.
Absolutely. I'm always glad to demonstrate my buddy here. Okay. Of course, you have to have the app loaded on your cell phone. Can everyone see that pretty well? You have to have the app loaded. And so you activate the koala, which again, Dr. Dwyer showed it, and it's about the size of an Apple earbud case.
And it's really great because we actually send it to the patient directly. And the app can be, how long did it take? I know you're not the most sophisticated app person, Donald, but a couple minutes to get it set up.
You're talking about Zoom, right?
Yeah.
Okay, so once you get to this point, you touch start, and then it tells you, okay, I understand is the go ahead. Now, in this case, it wants you to touch the heart that's on the koala, and it says, okay, it now wants you to put it on your chest. So I've got a look here. I just kind of put it right here, and it starts a 30-second countdown.
Great.
Right. At this time, it is collecting the data, the first channel, and it is being transmitted to the review station. How's it going, Donald?
It's going, well, we'll see. At the end of the 30 seconds, I'll get an alarm, and it will direct me to put my thumbs, there's the alarm, on the back of it, those two little sensors on the back. So I gently put my thumbs on the back of it, and it starts another 30-second clock.
Yeah, what Donald's symptoms was an irregular heartbeat, and that's why I brought up AFib, 9% over the age of 65. And my diagnosis going into starting the koala was that instead of the SVT, which Donald had a number of years ago, as the heart aged, he then went into atrial fibrillation, which was different, but also amenable to AFib ablation protocols.
Got it. And so, Jerry, as this data is being recorded, there is a center that's monitoring what's happening, right?
Absolutely correct. They have their proprietary kind of AI that is reviewing the data, as well as there's 24/7 coverage in the center. We set up parameters where I want to be notified if it's certain fast rate, certain slow rate, certain rhythms. But as I'll talk briefly, this is so important when somebody has simple palpitations that it really doesn't tie up the healthcare provider with normal heart rates. How's it going, Donald? Is it just
okay? I have a new screen here, and it asks me about my general condition, generally well, all the way down to palpitations and others. So I touch generally well, I go continue, and now it's sending the data and to both medical staff as well as back to my phone. And of course, it depends on the speed of the network, but it's typically pretty fast.
heart rate 76?
76, and it says your results appear normal, thankfully.
So maybe a minute and 30 seconds at the most. You can have the diagnosis. We have it recorded. It's in his medical file. If I had any doubts, I can call the center and review it. I do have it copied and transmitted, and I've been, if need be, notified anytime. If we,
And for the patient's convenience, you can go to a journal, which gives you
correct.
a listing of all the, I don't know how far it goes back, but it goes a long way back and to show you exactly what the previous diagnoses have been.
So Donald, what was your definitive treatment? Did you get an atrial fibrillation ablation this time?
I did it, and it was really the koala that identified it. I went into, I had, I don't know if I mentioned this, I had sinus surgery. And so while under anesthesia, I went into what was later diagnosed as AFib. The koala is what really diagnosed it. And then you prescribed another ablation, a second ablation that targeted AFib rather than SVT. It was very successful. That was in 2020. And that takes us up to the current. I have to say that I've always been impressed by the convenience and the ease of use of this little powerful device. I've used it at ball games, I've used it at concerts, church, restaurants, even in a car, and passengers side, of course. And that the koala has provided me with a tremendous amount of security. That professional medical help is only a few microseconds away. It's definitely my koala bear.
Well, thank you, Donald, for providing the experience from your standpoint. And Jerry, from your standpoint, tell me what's the game-changing aspect here about what koala is doing versus the halter and the patches and all your current methods of.
Well, I'm all about the data, and I just want to indulge me for 2 minutes to go through two quick scientific research. The FDA has, of course, cleared it, which is always important. And even during the pandemic, studies are still being done. There was a T study published in the British Medical Journal, October of 2020. The study evaluated 100 patients from 2 different stroke units in Sweden using the koala heart monitor for a duration of 28 days after what we call a cryptogenic stroke, which they did a morning and an evening as well as symptoms presentation. Cryptogenic strokes are strokes of unknown cause even after extensive medical investigation. From this study, remote monitoring with the koala detected undiagnosed atrial fib in 9% of the patients up to within 20 days on the average after the stroke. And the most remarkable thing was patients' compliance using the koala was almost exceeded 90%, which was the same comment that Donald just made of the ease and reliability, showing that koala on a regular basis and its reliability in detecting arrhythmias was great. And then the second one I just wanted to touch on was a Red Heart study that came out just March from Stockholm, Sweden. The Red Heart study used the koala heart monitor to evaluate over 800 women suffering from palpitations for a duration of 60 days. Palpitations are one of the most common symptoms seen in all patients. Koala can provide immediate feedback, like we just saw with Donald, of the ECG analysis when patients experience these palpitations. But it can also share that information with the real time with their physicians and caregivers. The feedback from the koala heart monitor reduced symptoms caused by palpitations, decreased feelings of depression and anxiety, and increased health-related quality of life. It also detected undiagnosed atrial fibrillation in this study, 4%, and diagnosed what Donald's first arrhythmia, SVT, in 3%. So those 2 studies, even during the pandemic from Sweden, provide reliability and data to support the use of, I believe, koala heart monitoring.
Very good, Jerry. So I want to now bring in Leanne Parker, who is a registered nurse who's been working in the Tennessee area working in a rural health setting. And Leanne, tell us briefly about yourself and how you got to the koala and what is it that you're planning to do with the koala in the Rural Health Center in Tennessee?
Hi, thank you, VJ. I had learned, well, a little bit about myself is I was in a bedside nurse forever, and then I went to national healthcare, and I got to take part in building a lot of evidence-based medicine platforms. And I built some of the first in the country, and I was very blessed and honored to be trained one-on-one by many physicians. I was a patient myself at the time, and honestly was bedridden a lot and on chemo. So I'm a nurse, and I'm a patient, and I'm a provider. And a policy builder. So I feel like I have a very unique view compared to most. And I saw, we heard a lot about social determinants of health. Everybody talks about them. Everybody talks about rural health, but like, I didn't see a lot of drive in there. And I wanted to take things that were being placed in front of me that I call like my bag. Like I told you, VJ, it's my bag. I can carry these mobile things and go into a rural area and fix stuff. We can fix it and just have a very pragmatic approach to what we're doing. And so for now, what we're going to talk about was the Helping Hands of Tennessee. And it was a rural dental clinic that was started about 2018. The CEO saw a real need for dental care there, and it was for the uninsured, underinsured, and they go by sliding scale. She did a mission of mercy where they triaged the patient medically before they went over to the dental section, where they provided a ton of free care, dentures, extractions, and she had like 1,600 people there. And it gave her an idea, and she's like, we need to bring medical and dental together. And so she's doing that. And then she tapped into me to see if I could bring anything to her, because I had met her when I first went into Tennessee, and I just adored her. So what we're going to do at Helping Hands is have complete patient-centric care. It's going to be a one-stop complete health center, inclusive of medical and dental, with social services, a food pharmacy, dietitian, traditional pharmacy with delivery inclusive of free medications, housing assistance and mental health. And the mission there is just to fill huge care gaps with the highest impact. And it's going to happen. I think it's going to be really cool. And then the next thing would probably be like what our patient population is. In Jackson, it sits right centered. It's like right between Nashville and Memphis. So they have an urban population, but they have a lot of rural patients. They're uninsured, underinsured, dual eligible. Some not very much are commercial. So Helping Hands was labeled as a safety net provider. And then
so the plan with koala for this patient population is what, Leanne? What are you thinking about?
So I wanted to take a different approach because I feel like we need better screening and tools and at point of care with real time. And we need to have immediate results, especially in these populations. It's hard for them to get back there, and we don't want to cause detours in their care. So right now we're going to use the 2-lead EKG there, and we're going to, when we're doing the vital signs on intake, and the AI in the background, the artificial intelligence, can assist us in diagnosing any arrhythmias. And that's really important, especially when they're going back and getting teeth extractions. If we find any abnormalities, like are discovered, or if the patient says, hey, I am having palpitations or an abnormality, we're going to order it as a remote monitor and be able to monitor the patient and take it to them.
Got it. So, wow. So while they're there, you'll be able to figure out if they've got any arrhythmia issues, and they're still in the dental clinic while this diagnosis has been performed. And then on a case-by-case basis, you'll be able to get a remote care monitoring going and potentially prevent an unnecessary mortality issue through this proactive approach.
Yeah, and I want to say something there, VJ, when you said that. When I first walked into the hospital that I used to be administrator at, they used to have plaques on the walls. And one of the plaques was actually a young lady who had died of an arrhythmia. I was an employee of the hospital. She'd worked, she said her heart felt funny, but she went home, and it really bothered me because I had the koala in my bag, literally had it in my bag. And I felt like if we can supply this and have things like this there, we could really save lives.
Got it. And so, Leanne, I want to now transition into the last part of our conversation and continue what we are just discussing here. And I want to bring in Marcus and Jerry. And what I want to have between the three of you is a discussion on, what is the new model of rural healthcare if we are trying to improve access and improve health outcomes. Obviously, this is a challenge that rural communities have faced. Urban communities face that too. But with the deep involvement that you've been having with the rural communities, we'd like to have a conversation around your thoughts about this. So, Marcus, why do you think, from your standpoint, the Babylon approach and the new care model that it enables is the future of healthcare for rural and underserved communities? Help us make that case.
Yeah, I think what you're seeing is it's a nice mix of taking proven models of care and combining it with the latest in technology, where they're just better together. I think, you know, in the earlier presentation when we were describing our model, you know, we're definitely seeing that and I think we've all experienced it during the pandemic, that healthcare really is something that can be delivered digitally. But we also know that for rural communities, there are some problems that still need to be dealt with in real life. And so it's important to have both.
Yeah, and so Marcus, speak to me about how a provider gets paid for can have a huge impact on solving for this problem. Because you have been paid on a fee-for-service approach, and you would have approached your population in one way, but you guys have full risk. And so talk about that difference.
Yeah, and this is where I get on my soapbox. But as somebody who's spent most of their life in healthcare and healthcare management, fee for service is just the wrong incentive, and so it's partly about breaking down those silos, creating accountability for the human being, and not the episode of care. It is putting the stewardship of how you use those resources in the hands of people who are closest to providing that care and being a part of that member's life, and then financially creating an incentive that promotes preventative care. What I would say is that this is about an incentive for health rather than an incentive for sickness at its most basic level.
Got it. So building on that, Leanne and Jerry, I wanted to understand from your standpoint. So, the problem we have is we'll never have enough cardiologists in every rural community. We'll not be able to, even if you did have them, the particular issue that you were talking about with arrhythmias, for example, they don't happen conveniently when you're in front of a doctor. They happen when you're living real life. And so talk to us about why a technology-enabled approach where the ability to monitor and know what's going on the patient's term is the new model of healthcare.
Yeah, I just want to jump in. I totally agree. It's timely access to high quality care that's fair and affordable. The other things we talk about, being able to access care without losing time from work, which is extremely important to a lot of my patients. The further away from St. Louis I travel, and provide health literacy to my patient population. I'm at one of the most resourceful hospitals. I start every morning, and I travel to some of the most remote clinics in all of Missouri. And the whole, I think it's not necessarily a result of the pandemic, but I think it heightened it, that 30% of my visits will be telemedicine, remote, over the years to come. And I think it's important that we embrace, review, and learn the technology. And it's really like the T study said, its ability for compliance and quick diagnosis with all those studies, and the overall quicker treatment, like Donald said, and I think you implied as well. VJ. So less time in the office, quicker time to diagnose, and basically, I think a higher level of care in some instances. And it's certainly a higher level for some of the inequalities in healthcare that we see here in Missouri. And I also do have patients from across the river in Illinois. Thank you for letting me butt in. And
No, good points, Dr. Dwyer. And
Yeah.
Marcus, what you said, like, I couldn't agree more. I think it's more preventative care and not disease care. We need health care in rural settings and urban areas. We need to be more preventative than we do actually treating disease. We're so disease care focused. And my biggest response to that, VJ, and what you said, is that we really, really have a need for point of care diagnostic and devices that provide real-time results that are essential. Those are just absolutely essential in rural health and urban areas of underserved communities. We need to utilize superior and supportive screening and evaluation tools in these rural and urban areas. And that's just an absolute must. And not only did I use the koala on my cardiac patients there, and I have a lot of use cases for that, but I also had another thing in my bag, like the Sure Touch, and it's a early breast cancer exam that it's the size of a computer mouse. And those two innovative devices I had taken into rural healthcare. And at the time, koala supported patients who were 2 hours from their specialist, like their cardiac doctor was in Nashville, right? And I was in another small community. And that cardiologist was at HCA in Nashville, but he was able to monitor his patients in that rural setting. And prevented them from having to drive there. If they said they had an anomaly or they didn't feel well, he could just automatically get on. He had them do a reading. He could listen to their heart, listen to their lung, and look in the portal with their reading. And that was really important in bringing the doctor to where the patient was, basically. It was a really, really important thing in that setting. And then also I wanted to bring a touch on that Sure Touch as the early breast cancer screening. It provided immediate results too, but we performed the Sure Touch exam on 94 women, and of the 94 women, only 2 of those women had mammograms. So I really feel like screening and identifying disease early is a major disparity and gap that we need to fill. And we can do it in a pragmatic, innovative approach with Koala, Sure Touch, these cool things that I have in my bag. And we can really drive change.
And I want to also mention to the audience, VJ, is that Koala is also Dr. Jen Silva, a pediatric electrophysiologist at Children's Hospital here in St. Louis, is going to be doing a pilot study with some of their young children. She tested it out on her own kids first, and they figured it out. Donald, maybe a little faster than you got it, but I'm teasing him. And so I think for your audience, these technologies can apply not only to, I am not a pediatric cardiologist, but also to the pediatric population, for family practice physicians, mid-level providers, as well as pediatric electrophysiologists. So great technology. And I wanted to make note that it really is a total, as we say, it could be part in your bag to fight heart disease. So,
yeah, and as I listen to you all and Marcus, and like to hear your comments on it, it feels as if being a more consumer-oriented provider, meaning understanding that first and foremost, it's about the people, it's about your patient, and then the care model is built around them. They are in the center of your life versus making them, you are the center and having them figure out how to engage with you. Comment on that for a minute here, Marcus, because that's a big shift, right?
Yeah, isn't it ironic that in an urban area where we're very consumer oriented because we're fighting for their business, but for a rural community, this is the difference between getting healthcare and getting no care. And so this is really the critical point, that it's not about trying to grab quote unquote business in terms of bringing the services and the access into the lives to meet the member where they are in that moment. This is about getting them the ability to take care of themselves and their families. It's truly as simple as that. And so I know that sometimes when we hear about technology and some of this fancy stuff, and you immediately begin to think about well-heeled people in urban areas, for the rural community, it truly, in some cases, is a matter of life and death. And this is a great fit for them.
Thank you so much, Marcus, for that comment. Jerry, were you going to say something?
Yeah, I was just going to say, I think we have to embrace, first of all, change. I say I reinvent myself every 6 months because the technology is so rapid and it's so important to our patient population and all healthcare providers, and as well as all people involved in healthcare need to embrace these changes and at least evaluate them. Look at the data, look at the outcomes, and look how we benefit our patients. And I was just thinking, I started taking care of some 65-year-old patients who are now in their early 90s. So that's the continuity of care. I take care of 3 generations of families, maybe even the 4th is within age of 3 or 4. But anyway, it is about taking care of patients, and they are at the center. And I applaud especially everything that we've talked about today, and it's an honor. So thanks.
Very good. So Leanne, anything you want to say to close it out? Because I want to then close out the webinar, and love to hear any thoughts you have.
I think all these things are great. I love them. Marcus, Babylon, I was always looking for a triage AI tool. I thought it was awesome. I did not know about Babylon, so I'm going to be digging into you a little bit more because I think it's an awesome asset. Dr. Dwyer and I are great with the koala. I think that we can find so many uses for it that it's going to be accelerated, I think. And VJ, thank you guys so very much. I really enjoyed it, and anything we can do to bring better healthcare to these rural and urban areas is just going to be awesome.
Well, thank you to all of you. Really appreciate Nathan and Marcus, you all coming in, talking about your project. As you know, what we are trying to do here is develop a new model for healthcare that is more patient-centric, that is on the terms of our rural communities. It is facing and understanding the realities of people who live in these communities and saying, okay, if that's what their world is, how do we make our world become part of theirs and bring value to them? That is what we are trying to do with this new model for rural healthcare. And what you have done today is showcase a couple of ways in which, through technology, but with this human-centric, patient-centric approach to healthcare, how that can be possible. So thank you for doing that. And we're really looking forward to a continuation of this conversation. So with that, I want to let the audience know that many of the questions that you had that we could not answer, we're going to take those questions back to the panelists. We'll get answers back from them and then distribute it back to the folks who asked those questions. So really appreciate that. Have a great day, everybody. And thank you for another great webinar.
Thanks, VJ.
Bye.
Take care.
Thank
Bye-bye.
you. Bye-bye.